right, good morning, everyone. Today I'm going to be presenting a patient case and giving a very brief overview of a disease, which is TBD. The reason I chose this topic is because it's a case that I heard about while I was on my PICU rotation. I didn't directly take care of this patient, but some of our colleagues did. Okay, just an overview of today. Thank you to the Small Talks team. All right, so it is fall in Brooklyn. The leaves are crunchy. There's some nice autumn aesthetic. You stop by Dunkin' for your pumpkin spice, and you walk into your UHB Peds ER shift. And this case was in September of this most recent year. You look at the board and you see a long list of waiting to be seen patients, all with the same chief concern: fever, cough, fever, runny nose, fever, sore throat, and you pick up the next patient. So your patient is a 13-year-old female, no significant past medical history, coming in today with 3 days of a fever. As per her mother, the T max at home was 101, as she's having abdominal pain and non-bloody, non-bilious emesis. Her mother also notes that for the past 1 day, she's noticed yellowing in both of her eyes, which is why she brought her back in. A week ago, they were seen at an outside ER for sore throat and fever, and had a negative rapid strep test at that time, was sent home with Tylenol, supportive care, and no antibiotics were given, as the PCR culture of the strep was still pending, but they did not hear back about it yet. Otherwise, the patient reported herself that she felt weak, but she was still able to eat and drink water at home. No other chest pain, shortness of breath, dysuria, rashes at that time. So you see the patient, and she looks calm, but she looks uncomfortable in the stretcher. She's afebrile in the ER, tachycardic to 111, saturating 100%, with a soft blood pressure of 99/64. On exam, she has diffuse abdominal tenderness in her belly. You can palpate bilateral cervical lymphadenopathy, which is tender, and she has bilateral scleral icterus. She is ANO ×3 and talking to you. All right, so far, we don't have much objective data yet other than our physical exam and vitals, but does anyone have any ideas? You can type it into the Zoom if you'd like. Okay, I can't see any of the typing, so if you want to say anything out loud too.
Lemierre syndrome.
Cool, yeah. So some liver pathologies, potentially with the scleral icterus. Still kind of a broad differential at this point. Anything we'd like to order? So probably just all your basic labs at this point. So we get the labs back, and the labs are notable for a couple things. High white count to 43, hemoglobin at 9.9, and thrombocytopenia, platelets to 21. The patient's hyponatremic, has an elevated alk phos to 274, and the BUN creatinine at 106/5.7. Dimer is elevated as well, and the patient has a positive UA. EKG is sinus tach. So at this point, you know that this patient is sick, and likely coming into the hospital. But before that, oh, okay, great. I can see some of the comments now. Before that, we're gonna do some imaging. So what type of imaging would you guys like? Ultrasound. Okay, Bilal, ultrasound of what? Do you want ECTs? So, okay, gallbladder. Yeah, so now we're thinking potentially something biliary versus in the liver. Obviously, there's some acute kidney injury or renal dysfunction going on as well. So still pretty broad differential. So this is the imaging. This is the actual clips of the images of the patient that she had initially with the chest X-ray, and a CT abdomen pelvis non-contrast was done as well. The X-ray showed multiple opacities in the right lung involving the hilar region. You can see there pretty clearly. The read read concerning for septic emboli. And on the CT abdomen pelvis, you can see there was hepatosplenomegaly, which I didn't include here, but the clip I did include shows multiple peripheral nodules in the lung with a small left pleural effusion. So you can see them there on the side, the peripheral nodules. So at this point, the patient was set up for admission to PICU with some of the differential at that time based on documentation were septic emboli versus multifocal pneumonia, also considering neoplasm versus endocarditis. So the patient was started on IV ceftriaxone. Consults were made to basically every subspecialty, renal, GI, hemonc, infectious disease, and the patient was then admitted to PICU. So a little bit, just a brief overview of the PICU course before we discuss the patient's pathology. A lot went on in the about 5-day course, and this was multiple subspecialty teams working together via multiple multidisciplinary meetings to try to understand what was going on with this patient. But to summarize, upon her admission overnight, she was admitted overnight, and overnight her respiratory status sharply declined. She required high flow nasal cannula initially, but that quickly went to BiPAP, and subsequently she was intubated due to increased respiratory requirements and repeat chest X-rays showing worsening infiltrates within the first few days of her being in the PICU. Of note, her official echo done on the floor was unremarkable, and her blood cultures for fungal and bacterial infections were also negative to growth to date. After being intubated, she required pressors as well as she became hypotensive. And one specific finding during her stay in the PICU was that the day before she was eventually transferred, she had a venous Doppler done of her upper extremity, which revealed a subacute DVT in her left internal jugular vein. However, the reason she was transferred is because she maxed out on her vent settings and needed high frequency oscillatory ventilation, which is something I feel like I personally need a whole hour lecture probably about to learn more about, but essentially it's vent setting with rapid ventilation rate and small tidal volume, and is used when you need escalation beyond the conventional vent settings that we have here available. So on day 5, she was transferred to an outside PICU to receive that, as well as plan to receive ECMO. Okay, so I saw in the chat that KJ wrote Lemierre's Zoidberg agrees. So good thinking, y'all. So yeah, we're going to talk about Lemierre syndrome today. This is I just want to point out, it's important to note, it is extremely rare complication, but when a patient has it, it is life-threatening. It's a complication of bacterial pharyngitis or oropharyngeal infection that spreads to the lateral pharyngeal neck space, and that leads to development of septic thrombophlebitis of the internal jugular vein. So although the incidence is 1 in a million since the advent of antibiotics, it used to be much more common. When patients do have it, the mortality rate is high, between 5 and 18%, even with appropriate antibiotics and therapy. So I still think it's important to have in the back of our mind and be aware of it. And this was a case that just happened in September. So I wasn't able to locate the outside hospital records after the patient was transferred, but I was able to speak to the resident who took care of this patient in the PICU, who did follow up about this patient's case. And they did share that, unfortunately, on the second day of the stay at the outside hospital, the patient became extremely hyperkalemic and went into cardiac arrest and unfortunately passed away. So a brief overview of Lemierre syndrome. I think it's easiest to see in this picture. So it starts as an oropharyngeal infection, which can be strep pharyngitis, but can also be thought about when you see patients with tonsillitis, PTA, EBV, mono, or dental abscesses. And usually that's kind of the starting source. The most common bacteria, about 90% is Fusobacterium necrophorum, which is an anaerobic gram-negative rod. And in Lemierre's, the bacteria spreads into the lateral pharyngeal space and the soft tissues, eventually, if not treated, invading into the cervical veins. So this picture kind of shows, kind of gives you an idea of the proximity to where this the infection in this pharyngeal neck area can spread to the vasculature. And once it spreads actually into the cervical veins, the bacteria aggregates platelets, which then cause thrombi formation and then dissemination of septic thrombi into basically all the endpoints of circulation, most commonly in the lungs, but also can be in the liver and kidney, which causes that multi-organ damage and multi-organ failure, as we saw in this patient. So when to consider Lemierre's. This is a syndrome you should consider in patients who either have current or recent oropharyngeal infections. Sometimes you don't see the effects of Lemierre's until 3 weeks or more after their initial viral infection, or sorry, not viral, their initial bacterial infection. In this patient's case, it was about a week later. Usually the patients who develop Lemierre syndrome have signs of sepsis already. You can see that in the labs, you can see that in their vital signs. But the thing to really look out for, to have you thinking about it, is the X-ray findings showing these septic emboli, because 97% do go to the lungs. So if that's something you're thinking about, you can think about further imaging to evaluate for that as well. So typically these patients who appear sick will probably already be planned for admission, but in the ER, things you can consider would be considering doing next CT scan or ultrasound. In this case, once the patient was admitted, was done to identify the thrombus, or CT chest to evaluate for the possible thrombuses as well. Regardless, if this is something that you're thinking about, and you probably would do anyways if a patient was septic, is to start antibiotics early on. So the literature right now is recommending that you choose a beta-lactamase resistant beta-lactam, such as Zosyn. You can add vancomycin if the patient is unstable, which in this case, the patient was. You can also choose ceftriaxone plus metronidazole works as well. Important to follow up blood cultures. However, in this case, the patient's blood cultures were unremarkable. Sometimes the literature says that because it's an anaerobe, sometimes it's hard for the cultures to show a positive. And then if the patient does have any existing abscess, like if the source is a PTA, to make sure that we drain that as well. Because of the nature of the IJ thrombus being a large part of how this pathology starts to disseminate through the body, there's been thoughts about anticoagulation. However, it's not well studied at all. I couldn't really find many studies that really looked at anticoagulation, as it's really controversial and not often used. However, like UpToDate still recommends against using anticoagulation, but can be considered if the patient's thrombus isn't progressing after treatment with antibiotics. There was one study with like 400 patients within the past 20 years or so, which showed that only 10 were treated with IJ ligation or excision, and didn't show that there was any significant effect on mortality or recanalization of the vessel for patients treated with anticoagulation versus not. So key takeaways: if your patient comes in with the recent or current oropharyngeal infection, who appear septic, who have signs of multi-organ damage, think about Lemierre's disease and consider next CT or ultrasound image, and make sure you administer early antibiotics. And that is the end.